Constrictions in esophagus. From upper incisor. 1. Pharyngosophageal junction at C6 15 cm. 2. Arch of aorta at T4 plus left main stem bronchus at T6 25 cm. 3. Diaphragm at T10 40 cm. What's the narrowest portion of GIT? Pharyngosophageal junction at C6 level. Foreign body impaction. Most common site of iatrogenic esophageal perforation. Pharyngosophageal junction at C6 level. Openings in diaphragm and their vertebral levels. T8 IVC, phrenic nerve. T10 esophagus, vagus, left gastric artery. T12 aorta, thoracic duct. I8-10 AGA 12. Blood supply of esophagus. Upper 1/3 road, inferior thyroid artery. Middle 1/3 road, descending thoracic aorta, bronchial artery. Lower 1/3 road, left gastric artery. Veins draining esophagus. Upper 1/3 road, inferior thyroid vein. Middle 1/3 road, azygous vein. Lower 1/3 road, left gastric vein. Layers of esophagus special points. Esophagus lax serosa. Strongest layer, submucosa. How much margin to leave in esophagectomy in cancer? Longitudinal spread and skip metastasis is there. So long premixal margin 10 cm taken. Which artery is involved in Mallory-Weiss tear? Left gastric artery. Upper esophageal sphincter made of. Both anatomical and physiological entity. Made of inferior constrictor thyropharyngeus and cricopharyngeus. Lower esophageal sphincter length and pressure. Only physiological entity, length 3 to 5 cm. Resting pressure 6-26 mm of mercury. Problem associated with frequent relaxation and no relaxation of lower esophageal sphincter. Frequent relaxation, GERD, no relaxation, achalasia cardia. Primary, secondary and tertiary peristalsis. Primary and secondary peristalsis waves are propulsive. Tertiary is non-propulsive. Its frequency increase with age. Foreign body coin in esophagus and trachea in AP and lateral view. In esophagus, AP view equals end face. Lateral equals side face. In trachea, AP view equals side face. Lateral equals end face. Management of esophagus foreign body. If impacted at C6 plus symptomatic equals endoscopic removal. Beyond C6 plus asymptomatic equals observation. Button battery equals endoscopic removal irrespective of site. Among acid and alkali intake, which damages more to stomach and which to esophagus? Alkali penetrate deep so damage esophagus more. Acid causes pylorospasm so affect stomach more. Management of corrosive injury, acid-alkali. IV fluid, early skilled endoscopy within 48 hours. Avoid blind insertion of ing tube for gastric lavage. No role of antibiotics, steroid. Esophagectomy of structure forms. Classification for grading of corrosive injury. Zarger, S classification. Types of tracheo-esophageal fistula. Type A equals esophageal atresia no fistula. Type B equals proximal TEF, distal EA. Type C equals proximal EA, distal TEF. Type D equals proximal and distal TEF. Type E equals TEF without EA. Type F equals esophageal stenosis. Most common type of tracheo-esophageal fistula. Type C, proximal EA, distal TEF. TEF is associated with what gene mutation? MYC. Features of TEF. Polyhydramnios in mother, excessive drooling of saliva, respiratory distress, coiling of OG tube on insertion. Diagnosis for TEF. Contrast study iohexol greater than dinosol. For H-type combined tracheo-esophagoscopy. On X-ray, stomach gas seen if esophagus patent or distal TEF. Other associated anomalies with TEF. Vactral, vertebral defect, anorectal malformations, cardiac abnormalities, TE fistula, renal, limb anomalies. Name of criteria used for the management of TEF. Waterston criteria. It considers birth weight and pneumonia. Management of type A TEF. If ends close, anastomosis. If far, gastrostomy, later anastomosis. Flourish devices magnets at ends. Management of type B, C, D, E, T, E, F. Cameron Haight surgery. Posterolateral thoracotomy to identify fistula, then cut fistula, repair trachea by polydioxonone suture, and anastomose two ends. Protective factors for GERD. 1. Intra-abdominal esophagus 3-5 cm. 2. Angle of His. 3. Pinching effect of diaphragmatic crura. 4. Arrangement of mucosal fold in stomach. Intra-abdominal esophagus length and less pressure in GERD. Length less than 2 cm. Pressure less than 6 mm of mercury. Risk factors for GERD. Obesity, low H. pylori rates. Clinical features of GERD. Retrosternal burn, water brash, pharyngitis, laryngitis, dental caries, chronic cough, wheezing. Investigation for GERD. Upper GI endoscopy, 24 hours pH monitoring. At what score on pH monitoring is suggestive of GERD? It's called Demeester score, greater than 14.72. Lifestyle changes for GERD. Weight loss. Avoid fried, fatty, spicy, citrus, chocolate, mint food. Small, frequent meals. Dine 2 to 3 hours before sleeping. Medicines for GERD. PPI, prokinetics, antacids. Indications for surgical management of GERD. 1. Not responding to medical treatment. 2. Suffering from GERD complications, Barrett's, stricture, adenocarcinoma. 3. Associations with sliding hiatal hernia. 4. Part wants to discontinue medical treatment. Surgery for GERD. Fundoplication, callus gastroplasty. Principle of fundoplication. 1. Restore intra-abdominal esophagus length greater than equals 3 cm. 2. Tighten diaphragmatic crura. 3. Wrap fundus around esophagus. 4. Preserve vagus nerve. 5. Re-establish angle of His. Types of fundoplication. 1. Nissen's complete wrap 360 degrees. 2. Partial wrap, door equals 180 anterior. 2. Pet equals 180 to 270 posterior. Belsey mark equals 270 anterior. Indications for callus gastroplasty. Esophageal shortening, so new esophagus is created out of stomach by firing a linear stapler. Most common complications of Nissen's wrap. Gas bloat syndrome. Newer modalities for GERD. 1. Polymer injection around less. 2. Esophageal radio frequency ablation. 3. Lynx device. 4. Transoral incisionless fundoplication. What's Barrett esophagus? Specialized intestinal metaplasia from squamous to columnar epithelia. Pathognomic finding in Barrett esophagus. Red velvety mucosa which one biopsy show presence of goblet cells. Types of Barrett esophagus. Long segment greater than 3 cm. Short segment less than 3 cm. Cardia metaplasia, microscopic Barrett. How is microscopic Barrett identified? Chromoendoscopy, Lugol's iodine for squamous epithelium, methylene blue for Barrett. What criteria decided risk of cancer in Barrett esophagus? Prog C and M criteria. What's C and M value? Identify GE junction. Calc distance of GE junction to max point where Barrett is extending M value. Find the point till where there is 360 degrees full circumferential involvement of Barrett C value. What's Seattle biopsy protocol for Barrett? 4-quadrant biopsy every 2 cm. Step to follow if no dysplasia, only Barrett esophagus present. Repeat OGD endoscopy plus biopsy every year for 3 to 5 years. Step to follow if low-grade dysplasia in Barrett esophagus present. OGD every 6 months until 2 consecutive evidence of non-dysplasia Barrett. Step to follow if high-grade dysplasia or cancer with Barrett esophagus present. Multidisciplinary team discussion, esophagectomy.